Thank you so much for joining us for our next session. The topic will be advancements in hemodynamic monitoring and treatment. We're just going to jump right into it with our first talk from Dr. Mark Belkin from UChicago.
Hello, make sure this on. All right, hi everyone. I'm Mark Belkin, one of the advanced heart failure cardiologists at the University of Chicago. Thank you for having me, inviting me to talk about hemodynamic monitoring, and I'll be introducing kind of the panel before we go through some of these lightning talks. I have no relevant disclosures. I will be talking about some devices under investigation. So, heart failure hospitalizations are a significant burden on our patients with heart failure. We know they're associated with a very high all-cause mortality on the order of 50% at 2 years and 75% after 5 years. Put this into context for some of the other rooms that are going on this weekend. If you compare to recurrent ASCVD risk, our most stable patients with HFrEF, with NYHA2 symptoms and no recent heart failure hospitalization are still at higher risk than some of the very highest ASCVD risk patients. So when we focus on a lot of the treatment for these heart failure patients, we're looking at how do we prevent decompensations, predict progression of disease, and palliate their symptoms. There are a lot of medications, devices to do this, and obviously here we're going to be talking about remote hemodynamic monitoring. Remote hemodynamic monitoring gives us the opportunity to identify these patients days to weeks ahead of their heart failure hospitalizations and therefore do our best to prevent it by treating those symptoms ahead of time, long before patients have symptoms, or kind of more basic technology like just a weight scale before those numbers change. The data largely from things like the Champion trial, Guide HF, and some other trials in between led the 2022 heart failure guidelines to have a 2B indication to consider remote pulmonary arterial monitoring for patients with NYHA class 3 symptoms, recent heart failure hospitalizations, or elevated BNP on maximum tolerated therapy to reduce heart failure hospitalizations. However, as many of us will think about CardioMEMs and other remote monitoring devices, you might think about all we can do is adjust diuretics. But we should be able to leverage these data, the information we get from these devices, to help our patients. One way to do that is not just adjust diuretics, but also adjust their guideline-directed medical therapy. This is data from the ProActive 1 trial with a Cordella system, which is also tied in with a blood pressure monitor and weight scale, in which they showed not only were they adjusting diuretics during the trial, but patients were adjusted on all 4 pillars of their guideline-directed medical therapy, which of course are associated with improvement in mortality, not just reduction in heart failure hospitalization. We can use pulmonary artery sensors to predict as patients' disease advances. This is a multi-center study that shows significant increases in mean PA pressure in patients in the 3 months leading to their LVAD implantation. Data such as these have led to the Team HF trial, which I believe is now ongoing, which is trying to leverage the use of the CardioMEMs device, not only treat patients, but identify the optimal time for progression for use of advanced therapies such as LVAD implantation. Of course, as we use more of these devices, we may be increasing the burden on our RNs, APPs, and physicians. So following FDA approval for NYHA3 symptoms with the Cordella system, the current ongoing ProActive 2 trial not only is expanded to NYHA class 2 patients, but has a sub-study in which participants are randomized to be able to see their pulmonary artery pressures themselves and adjust the diuretics based on an algorithm compared to just using clinician alone. And of course, this can empower patients to take more control of their health as they do as we use, for instance, weight scales and have patients adjust in that manner. Now, beyond that, how do we use these devices and novel devices under investigation to address many of the debates we're having in hemodynamics? So I don't need to tell Dr. Fudim about upright versus supine hemodynamics, but we know when you're upright, your pressures are lower. And while this does relate to diagnosis of things like such as HFpEF, trying to find the optimal target for your patients, we all have patients who are congested, feel bad, but then are lightheaded and dizzy. So using the Cordella system, which you can measure patients' pressures in the sitting position, which is not only comfortable for the patient, but may assess different targets as you can do both sitting and supine pressures. We know pressure doesn't always equal volume. Dr. Fudim and his colleagues have shown us that pulmonary artery diastolic pressures don't correlate very well with total blood volume as measured by blood volume analysis. The FIRE1 device implanted in the IVC measures the IVC diameter as a measure of volume over pressure. The current approved devices all measure pulmonary artery pressures, which are, of course, surrogates for pulmonary capillary wedge pressure, which, while can be linear, tend to decouple as patients' disease progresses all the way. The chart on the right is patients in cryogenic shock, where they're essentially almost not related. So there are devices under investigation, such as the VLAP monitor, which is implanted into the interatrial septum to directly measure wedge pressure. There's Microtech, which is, as you can see, quite small compared to the SPENDI, that can be implanted during cardiac surgery, for instance, into the left atrium to measure wedge pressure directly. And of course, we're not going to be able to implant invasively into the millions of patients with heart failure that would benefit from these devices. So there are a whole suite of both approved and under investigation, non-invasive technologies, many of which are, more data are coming soon, that we can more easily expand to our population. So there's a lot of exciting advancements on the horizon, and I'm looking forward to the lightning talks from the panels here. And if you enjoy talking about hemodynamics and debating them, please do come to the second annual Chicago Hemodynamic Forum, and there's a trainee education day for any trainees in the audience. You can register online. Thank you.
Thank you so much. We're going into our first lightning talk. Dr. Kanwar, also from UChicago, will be presenting on the CardioMEMs device.
The whole forum is Chicago. Awesome. So it's funny, Michele told me to give this talk on CardioMEMs, but not to refer to any device by name. So I'll just call it the device, I guess. So just over the next 5 minutes, in case you're not very familiar with what CardioMEMs is, the idea behind it is if you have a patient with HFpEF or HFrEF who is prone to needing their volume optimized, they're usually doing okay, and then comes a period of time when they are undergoing worsening hemodynamic congestion. At this point, this has not manifested as physical symptoms or signs, which is what we traditionally would rely upon to say if this patient is gaining weight or feeling more short of breath to increase their diuretic dose. But the idea is you precede these clinical signs of congestion with what gets picked up with devices such as CardioMEMs and other implantable and non-implantable devices, and therefore you gain at least 2 weeks approximately to intervene these patients and prevent rehospitalization, which is the whole premise of the device CardioMEMs and the theory of how it got approved for heart failure patients. As Mark mentioned, it's currently approved for NYHA class 2 and 3 patients, whether they have HFpEF or HFrEF, who've had a heart failure-related hospitalization in the last 12 months and or have an elevated pro-BNP. And the idea is you get these readings shown here on the right, which show you the PA systolic, diastolic, and mean, and allow you to monitor this patient, adjust their medications, not just diuretics, but also GDMT titration, allowing them to do better overall from a symptom as well as mortality standpoint. This, of course, came to fruition based on the results from the CHAMPION trial, which was done in NYHA class 3 patients. I'm sure you're very familiar with it. Both reduction in heart failure hospitalization and death and overall total heart failure hospitalizations as well, which was followed by GUIDE-HF trial. I'm not going to go over all the pre-pandemic and post-pandemic data, but the gist of it was, again, it avoids rehospitalization and decompensating events if you use a treatment guided by CardioMEMs in this particular cohort as was shown. And of course, since that time, multiple other trials have been published in this arena. And overall, you see the recurrent theme is reduction in overall rates of heart failure hospitalization in this patient population that is otherwise very prone to this morbidity. Now, this is just some, data shown by Dr. Mark Zile at THT from a few months ago, which talked about how they looked at baseline pulmonary pressures as well as follow-up pulmonary pressures and saw the delta and correlated it with 2-year mortality. This is based on several thousands of patients who receive CardioMEMs device as part of clinical trials. So this is kind of collective analysis of this data. And it showed that the PA diastolic pressure, which is what we often monitor in this patient population, can correlate with the probability of death at 2 years post-implant. Not just that, it's not just the PA diastolic, but also the PA systolic, PA mean, both in HFpEF and HFrEF, which has very similar trends to predict 2-year outcomes in this patient population. And lastly, it's not just the baseline pressures, but also the delta in the pressures, what they are at, as was shown in the figure ago, between baseline and 6 months, that can predict outcomes across this patient population, sort of picking up this susceptible population to be able to then, again, not just adjust diuretics, which is what we were traditionally doing, but also increase GDMT, which is, I think, the key of reducing truly heart failure with reduced ejection fraction function. So again, we've moved beyond just reduction in heart failure hospitalization, but also significant improvement in mortality because these patients are tolerating higher and higher GDMT doses, which is sort of the premise of the Team HF trial that is actively participating. So this is all patients who are in the NYHA class 3. The idea is to understand, does LVAD have a role? That was sort of the premise of a discussion from the last forum. If done earlier, do we have data to show it will improve morbidity and mortality? And the gist of it is you use CardioMEMs as a screening tool. And if despite all GDMT optimization attempts, which is the key, their PA diastolic remains above 30 millimeters of mercury, then they're randomized to GDMT ongoing arm versus LVAD, HeartMate 3 LVAD, and the results of this are obviously still pending. There are about 30 patients at this time enrolled and just a couple randomized, which we are excited to all be a part of. So thank you for your time.
Thank you so much. Our next lightning talk will be by Dr. Kunjan Bhatt, who will be talking about another PA pressure monitoring device, Endotronix.
Thank you, and good morning. My disclosures. So just a brief history of ambulatory PA pressure monitoring without going into extensive detail. In May of 2014, the FDA approved the CardioMEMS PA pressure sensor based on the results of the CHAMPION study published years before. That was May of 2014. I'm proud to say our institution was the first in Texas and one of the first in the country to implant CardioMEMS in September of 2014. So we've been doing this now for about 10 and a half years. Ironically, almost 10 years ago to date, the Cordella PA pressure sensor was approved last June, and that was on the basis of the PROACTIVE study, and we were the first in the country to implant that post-FDA approval. So the Cordella PA pressure sensor system is similar to its competitor and also has some unique characteristics. It is a PA pressure sensor that's designed to be implanted in the right pulmonary artery. The sensor allows for pressures to be checked in both supine and seated positions. And there's a tablet and there's a patient engagement system that really makes this platform quite unique. And that is the monitoring of vital signs, weights, along with PA pressures on one platform on one website. So the access is very similar to CardioMEMS. You either go femoral or IJ, baseline hemodynamics. You look at your right pulmonary artery, place a wire, deliver and deploy, and then you close. The PROACTIVE study, which we'll go into briefly, showed a significant, almost a massive reduction in heart failure events. What was nice to see is that patients were highly engaged, checking their transmissions most days of the week, and were very interested in seeing their data. On the time piece for the patient, it's less than 5 minutes a day, and that's checking the sensor, but also collecting their vital signs. Seeing the clinician side and the patient side, it's nice to see that the patients have something to look at. Currently, with CardioMEMS, they do not. On the clinician side, a very similar platform to what we see with CardioMEMS, with the addition of heart rate, blood pressure, weight, O2 sat. It's nice to have those data points as well. So again, just some key differences between the two. We have the ability to check PA pressure sensors supine and seated. Integrating the vital signs to the website makes our management piece a little bit easier. The handheld reader is a quality of life win for the patient. And the interactive tablet also is very easy to use and patient-facing and patient-friendly. I'm not an interventionalist, but I think the delivery technique is very similar to its competitor. It's a 10-French sheath, and the device size is bigger, and it sits in a different part of the real estate of the pulmonary artery, which is a key difference, but similar in concept. So what's the data? PROACTIVE 1 and PROACTIVE 2. PROACTIVE 1, which my colleagues have briefly discussed, was a heart failure study of functional class 3 patients, and the endpoints being heart failure hospitalizations or all-cause mortality compared to a performance goal. And then there were safety endpoints and there were secondary endpoints, including quality of life. Looking at baseline characteristics, this is a very well-done study and looked very similar in terms of the patient cohort to its predecessors, with a couple of key interesting points. Females, 40%, that's great. Not quite where it should be, but it's getting close. Non-whites, almost 25%. SGLT2 use, almost 60%. Remember, this was sort of in the upstart of SGLT2 inhibitors. Looking at the safety endpoints, the device implant is safe. Much like we know, this is not new news. So the device implant is feasible, doable, and safe. The primary effectiveness endpoint, there was a significant reduction in heart failure events compared to historic controls. If you look at the treatment arms for GUIDE-HF, MEMS-HF, the European study, post-approval study, and CHAMPION, their event rates were almost double or almost triple. I think this owes to the fact that medical therapy was better, but also that patients were highly engaged in the study. So the primary endpoint was met. There was a significant improvement in the primary outcome. The sensor was safe to put in, no major bad events happening. And this definitely supports the use of both supine or even seated PA pressure monitoring in managing patients with heart failure. I'll just briefly go into ProActive 2. I don't have much time. So in ProActive 2, this is a very large trial and a large undertaking by the sponsor of over 1,000 patients in a class 2 cohort that'll get randomized into treatment versus control. You remember the control here is going to have access to their vital signs through the platform, so they're a active control arm, if you will. In that active control arm, after 12 months, they can cross over into PA pressure monitoring. In the class 3 cohort, this is going to be an interesting trial design where patients are randomized 2-to-1 treatment to control, and after 6 months, the patients in the treatment arm can actually then be, the PA pressure data can be available to them for self-management. So I think the key in this trial is going to be the ability for patients to manage themselves. And is that safe? Does it work? How will that do? I think we're all excited to see what that shows, because if patients can manage themselves, unburden the clinic, unburden our staff, and have good outcomes, that will be the win for PA pressure monitoring. In the interest of time, I will wrap it up. Thank you.
Thank you so much. We're going to skip Dr. Uriel's talk. He unfortunately had a last-minute conflict and regrets not being able to be here, but we're going to move right ahead, again with my co-chair, Dr. Fudim, who's going to be discussing volume sensors.
Okay, so we talked a lot about pressure with the... Here we go. Made me nervous there for a second. So I was asked to talk about volume sensors. Actually, it's a talk that I had to jump in to cover here for a second. But the idea that, so we talked a lot about pressures. We love pressures in the heart failure space. The problem is when we say pressure, we really probably in most cases actually mean volume. We often equate pressures to volume, and you know the number one intervention in any of the trials you just showed were actually diuretic therapies as a treatment for elevated pressures, because that's what we love to do. I often get insulted being a heart failure doc is nothing else than push diuretics, right? The problem is that if everything above the yellow line, this closed system, is pressure, it might not represent a volume status change, because volume can be just simply distributed in the system, aka the arteries and veins, which is a closed system, for vasoconstriction. Thus, in many cases, we see a pressure overloaded state in the absence of volume gain. And the way to explain is that you could actually have a volume distribution process which is driven by the autonomic nervous system, and that is actually recruitment of blood volume from the periphery, referred to stress blood volume. To demonstrate it differently, we just actually put it to the test. There is a volume sensor, but that's not a technology. It's actually a drug. It's a radiodilution technique, a company called Daxor, that you can inject a radiotracer, measure the intravascular blood volume. That's the volume we actually address with our diuretics. Our diuretics do not go to the toe to diurese the water out of the extravascular compartment. It's an intravascularly active drug first. If you compare on the x-axis the pressure on a CardioMEMs tracing versus the volume on the y-axis, there was no correlation between pressures and volumes. There's no correlation with pressure and volumes. This is a moot point to compare those two. This is not a new analysis. And there's really, the reality is that the majority of patients in the ambulatory heart failure setting implanted with CardioMEMs were in the blue zone. Blue zone is high pressures, PAD greater than 15, but had normal or low volumes. The majority of patients running around are likely high pressure, but a normal or low volume state. They're in many cases probably over-diuresed. This is an acute heart failure study we have done. We have demonstrated that within 24 hours of admission, a third of the patients were in the euvolemia zone. They had normal blood volume, green zone, or to the left of it was dry. So even at large major academic centers where everybody gets IV diuretics no matter what in the first 24 hours, a third of the patients didn't have volume overload to begin with. Now, the problem becomes that if we to even equate pressure and volume, that they are not actually, they wouldn't even be in a linear environment. And here's the explanation for that. The venous system is the largest capacitance system for the vascular, in the vascular system. So majority of blood sits in the venous system, predominantly in the abdominal cavity. And it takes quite a long time for the veins to distend before they translate volume overload into a pressure overload and vice versa. So on the right side is really what you see in that circle. That is usually when you see pressures rise, when you start overloading sheep models, for example, with volume, relatively late in the case. Having said that, prior to that, the IVC, which was tested here, started already distending for quite a long time. So a dedicated sensor was developed. Look at me. I have a sensor in my pocket. For those that you actually want to look at CardioMEMs, Cordell, I have brought actually all of them randomly from my lab. So here you go. I hand it out. I hand it out for you, Esther. So this is an IVC sensor. It's pliable system, look like a vena cava system, but nothing in the middle. It's not a vena cava cover filter. It's very pliable, has little barbs. You wear a belt to actually measure the translation of IVC collapse and total area. These are two metrics this device measures. 2 studies have been completed. Kunjan Bhatt is actually the #1 enroller worldwide. Congratulations. And the 2 studies have demonstrated essentially safety, and it really measures what it's intended to do. It measures like a POC ultrasound, point of care ultrasound, the area and the collapse, but a much higher resolution. When you start looking in clinical space, those patients that end up being decompensated and hospitalized, just like we showed with pressure-based sensors, the red line is those that end up getting hospitalized. Guess what? The area rises over time. Those in blue where the area remains normal will not be hospitalized. Now, the interesting thing is that still, like in many other trials, diuretics were the most common therapy utilized, but the graph on the right side is actually fascinating, is that if you take all patients, around 60 patients have been treated today, if you look at what happened to the IVC area after initiation of the therapy, they had an average of reduction of around 4 or 5% of the IVC area as soon as they get included in the trial. Similar to the CardioMEMs trial where there were the reduction of pressures. But look at the weight which was measured at the same time in clinics. The weight didn't change even though the IVC area was reduced. So again, pressures and volumes are disconnected, weight being a surrogate of total volume loss. So it's really in many cases just the GDMT titration that reduced the vascular tone, opened up the veins. All right, I actually can skip all my conclusion slides. Thank you very much.
Thank you so much. We're going to move on to our next talk. Dr. Hernandez-Montfort is presenting on mechanically reducing cardiac preload, concept and practice.
Well, thank you. It's an honor to be here and share the conclusions that, yes, congestion is complex, and now we have learned through innovation many of the insights that are leading perhaps the next phase of therapies for ADHF. So it's important to start with the factors that influence preload. Dr. Kanwar, which is here, and Dr. Burkhoff, which is here, came up with this really excellent paper in which, again, explained that there's multiple vascular factors, cardiac factors, systemic factors, and thoracic factors that influence preload. When we look at this through the guiding light of pressure volume loops, we can perhaps better understand what will be the impact of preload in the failing heart at different levels and how this truly affects the end diastolic pressure volume relationship. You can see a lot of these pressure volume loops have been focused on the left heart, and perhaps as we learn more from the IVC, et cetera, all the talks that have preceded this one, we can also start coupling right and left heart as well. In this setting, the clinical challenge of diuretic resistance is such in which the definitions of the contemporary trials, as you can see, are in a way heterogeneous, mostly depending or connected to gross urine output. As we try to understand better diuretic resistance, which I think in this sort of Sentinel paper, review article from Nature Cardiology, I mean, as we understand diuretics, there's multiple complexities behind that, sequential nephron blocking, et cetera, but there's only, that's part of the tip of the iceberg, I guess. In that sense, I think there has been a revolution in the last perhaps 5 years in trying to address this evidence gap in IV diuretic resistance, particularly for the population of acute decompensated heart failure. And again, we have multiple trials trying to address in different ways, such as urine chemistry, guided titration strategies, loop diuretic dosing, and sequential or next diuretics choice. And all these trials are really trying to look across the continuum of ADHS, IV diuretic strategies, perhaps focused on only one therapy. We have now also learned that there's beyond urine output or total urine output better or distinct ways to assess diuretic responsiveness, just such as urinary sodium. And as we can see in the trials that are contemporary, we have multiple trials that are now including natriuresis as their primary endpoint. However, a lot of these trials haven't really changed the trajectory of, in terms of mortality. Perhaps length of stay has changed. So still a lot of work to be done in that area. I think that one of the trials that are still pending to come out has applied or incorporated clinical diuretic goals and also natriuretic goals into their endpoints, which I think is relevant and connected with what we already learned in the prior trials. I think the hemodynamic connection here will be very important as well. Instead of devices for mechanical preload reduction, we have passive devices that are predominantly IVC, like the original Herrera balloon, Doraya, Nephronyx device, that again, they're passive, they're not connected to the cardiac cycle as compared to the active devices for mechanical preload reduction, such as the preCARDIA device that deflates and inflates during the cardiac cycle, and it's placed not in the IVC, but in the SVC. So preCARDIA has done already several early feasibility patients. The first 30 patients were published in 2022. I think the next iteration of their patient cohort is coming up. It's about 60 patients. And as you can see, in terms of safety, it's a device that is being deployed by the advanced heart failure specialists or people that have right-sided procedure skill sets. In terms of adverse side effects, I think it's a low rate as well. But again, preCARDIA was focused originally in trying to prove a hemodynamic effect of reducing RA pressure and pulmonary wedge pressure, but also focused on urine output with an increased diuretic therapy and without an increase in their diuretic therapy as well. So again, the endpoints here were focused on urine output in total. As the next iteration of the study follows, now they're looking at perhaps better technology with a third generation device and perhaps distinct efficacy endpoints. I think the future here is based on what we learned in the clinical setting of the impact that this active mechanical preload strategy can achieve, particularly in patients that have already temporary mechanical support for the left heart. And it has been proven in distinct settings that activating mechanical preload with transvalvular pumps in the left side enhances the capacity of those pumps. So again, in terms of the future, perhaps we'll be trying to combine and see the effects of mechanical preload devices with temporary MCS as well. Thank you.
Thank you. For our next lightning talk, we're going to move to Dr. Vorovich, who is going to be presenting on the preCARDIA device.
Hey guys, so Jaime stole some of my slides. It's okay. So I'm going to be talking about preCARDIA here, my disclosures. So, you know, when we talk about different mechanisms for addressing cardiorenal syndrome and ADHF, a great paper that kind of talks about the different mechanisms. There's the pushers, the pullers, and I'm sure we'll hear about some of the others at some point during this conference. preCARDIA falls into this pullers category, which is really aimed at mechanically decreasing preload. So what is this device? It's a very fancy version of a swan that has this SVC occlusion balloon. The first generation started off as a 14 French, then 10 French, and the third generation supposed to be 9 French. It goes in like a swan through the IJ, and you could see the monitor up here. It has a lot more technology than a regular swan, but it, like a swan, has a PA port, PA balloon, and then has this SVC occlusion device with the concept being intermittent occlusion, and it cycles through occluding and not occluding. So, you know, some representative chest x-rays at the bottom. Obviously, the SVC has to be measured. It has to be big enough, which is 2 centimeters. And then it has to be positioned. And you want to position it, obviously, between your sheath and SVC-RA junction, with the caveat that I'm also not an interventional cardiologist, and I don't put these in. I mean, I do put swans in, but not these. So, the main study, and I'm going to go into a little bit more detail, otherwise, Jaime did most of my slides. So of the Venous HF trial, this was the early feasibility trial, 30 patients, pretty sick, heart failure patients, multi-center. These were class 3 or 4 patients that were congested and were having inadequate diuresis. Pretty expected exclusion criteria. You couldn't be really sick. You could be sick, but not too sick. No shock, no significant valvular disease, no significant RV dysfunction. Volume-wise, you had to, or pressure-wise, you had to have an RA pressure of more than 10 and a wedge more than 18. And so you'd go to the cath lab, you had this, you get a venogram. If your SVC is big enough, you'd get enrolled. So it was a 14 French sheath at the time. They would do a venogram to confirm placement. And they would also, you'd want to see a pressure gradient between the right AJ and the right atrium of 5 with inflation that went away without. And the protocol in the study was 5 minutes on, 30 seconds off. Patients were anticoagulated. The first 6 patients were treated for 12 hours and subsequently for 24. Primary endpoint, this was an early feasibility study, so your primary endpoint was really, was it safe? So freedom from procedure-related events. You know, they were including the SVC, which is cerebral venous return. So these patients were very closely monitored from a neuro perspective. Secondary points were technical success and hemodynamic success. This is the table 1, nothing too exciting to point out, but it has to be included, just your typical expected heart failure patients. Of note, 2 of these patients were on inotropes before this, 6 were on inotropes during this. In terms of primary endpoints, freedom from adverse events was 100%, again, 30 patients. In terms of acute technical success, 30 patients, they were able to place the device, but in terms of being able to deliver treatment to have it appropriately positioned, was 29 out of 30. Procedure time was 22 minutes, plus minus 12 median, so a bit longer than a swan, but not crazy, crazy long. The range was wide, from 5 to 51 minutes. In terms of hemodynamic effects, that's the figure on the right, they saw a pretty substantial change in wedge of 20% and 27% for right atrial pressure. Notably, there was no significant change in cardiac output, index, MAP, or creatinine. When they did the pre-animal studies, interestingly, IVC occlusion did drop cardiac output and MAP, but SVC did not. When we looked at urine output, we saw a significant increase in urine output with supported device, and then even after the device came out, although that did go down. And this was in patients, the left panel is all patients. On the right, the top is those who had an increase in, who did not have an increase in diuretic therapy, and those on the bottom are those who did have escalation diuretic therapy. And what you can see is that in all the groups, whether you escalated diuretics or not, there was increased urine output. So if we had to place it in context in 30 seconds, this is a novel approach to mechanically reduce preload. The mechanism has face validity, and there's actually multiple other putative mechanisms. We obviously need proof of efficacy and superiority. But as we think about that, we have to figure out what's the patient population, right? We don't have a good definition for diuretic resistance. And even if we did, do we want mild diuretic resistance? Do we want severe diuretic resistance? Again, we don't have good definitions for any of those. We think of diuretics as easy and risk-free, but they are not, but neither are devices. So device complications will end up being pivotal in that risk-benefit decision. We're gonna have to figure out what success looks like. Are we gonna look at clinical outcomes? Do we care more about clinical outcomes, soft outcomes, how people feel, or do they get readmitted less, length of stay? And then just as we're mainly at an interventional conference, but these patients are really, really sick, and we need more heart failure docs. And so we're having trouble recruiting people into our field, but it's a really fun field. And Sandeep was falling asleep as I was saying this, literally as I was saying this. But we're a really fun group of people. It's a really fun field, and we need more heart failure docs. So encourage people. That's the main message.
Thank you so much, and thanks everybody for staying on time. We're doing great with time. We're going to move into our next lightning talk from Dr. Sandeep Nathan from UChicago. A lot of UChicago representation on the stage today, who will be speaking about the Nephronyx device.
Thank you very much, Michele, and organizers of CVI for having me. The stage is like infested with Chicago people. Okay, so I'm going to talk about the Nephronyx Perfuser. These are my disclosures. So, a little context for venous decongestion using device therapy. CRS in decompensated heart failure really postulates that low cardiac output is the primary driver of all the hormonal changes sodium retention, water retention, and so forth. However, there is a growing body of data suggesting that that cardiac output or index is not the primary bad actor here, and this paper from 2009 very nicely demonstrates that the ROC curve for CVP is more predictive of worsening renal failure than cardiac index. And in that data set, chunking these patients by low CVP versus high CVP, you could see that high CVP patients are more likely to be associated with reduced GFR at the time that the PA catheter has been removed. And so venous congestion is maybe not the most important hemodynamic factor, but it's certainly a factor that's been overlooked as we sort of flog these patients with inotropes and consider mechanical circulatory support. This is a beautiful central figure from a review paper in 2023 looking at all of the addressable territories with renal device therapies, breaking it out into venous congestion, arterial underfilling, and interstitial overload, which are represented separately but obviously have considerable overlap between them. This is the central illustration from a paper that Babar Basir and I wrote for JSky in 2023, breaking out the pullers and the pushers, that is the devices to address venous congestion, as the pullers and the devices to augment arterial perfusion as the pushers. On the puller side, the Magenta TRVD device has been sort of backburnered in favor of moving forward with the Elevate pump, which is in clinical trials now. So hopefully that'll come back at some point, but that project has been shelved and the other projects look like they're going forward. So here's the Nephronyx Perfuser. It's a unpowered covered stent that's deployed through the femoral vein, 9 to 10 French access, potentially even smaller in the future, aimed at improving kidney and cardiac function by decreasing renal venous congestion. And so you can see that there's a constrained portion of this device that utilizes the Bernoulli principle, among other things, to create a pressure differential in the inferior vena cava. It is untethered, as you can see. It's also retrievable, very similar to an IVC filter, which is relatively simple to place in the cath lab, whether it's from an IJ approach or from a femoral venous approach, as this is. A little bit about the Bernoulli principle and entrainment. The concept here is that an increase in velocity of fluid or gas corresponds with a decrease in pressure, and that decreased pressure zone entrains surrounding gas or fluid into that stream. If you've ever seen a Dyson bladeless fan, this is operating on the Bernoulli principle. Anybody who flew here, you flew here on the Bernoulli principle. It's what gives airplane wings lift when the camber of the wing goes up. And so it is a very elegant solution for entraining surrounding fluid and air around a high stream jet, as you can see here, or a reduction in pressure in the Nephronyx device. So here's N of 10, the first in human study. This was presented at THT in 2023, looking at patients with acute decompensated heart failure without cardiogenic shock and with some measure of elevated CVP and diuretic resistance. Some of the key enrollment criteria are described on this slide. As of this talk, the trial appears to still be open exclusively in Israel. I wasn't able to find anybody participating in this locally. I don't know if you guys know of anybody. Very interesting device, and as an interventionalist, that's my disclosure, I'm an interventionalist sitting with a bunch of smart heart failure people. We will mostly agree that simplicity equals elegance. However, in our world, simple things usually don't work very broadly, and it does require a little bit of complexity. That would be my one and only critique, but I'm prepared to be convinced otherwise. A little bit more about the trial eligibility criteria, which is fairly standard for this type of device. And my last slide is obviously not a Nephronyx device. It's our first implant of the preCARDIA device. And I just put this up because I think that getting into this space, at least for us as interventionalists, really begs a lot of questions about hemodynamic profiling to find the person that's best suited for a pusher versus a puller, or perhaps even devices in combination. And with that, I'll close and put in a shameless plug for the SkyShock meeting happening in just under 2 months in Tampa. Please join us.
Cut the slides.
What's that?
I said cut the slides.
Please join us. There's something for heart failure people there as well. Thanks so much.
All right. Next up, Dr. Esposito. She'll be talking about another venous return reducer, and this is the Doraya system.
Thank you so much, everybody. Thank you to the organizers of the conference. Thank you to my fabulous co-chair, Marat. Thank you to all of our panelists and all the other speakers for taking the time out to fly down here to sunny Texas, which is actually slightly hotter than Charleston right now, which is where I hail from. So appreciate everybody being here today and for contributing to the discussion. So like Marat said, I'm going to be discussing the Doraya catheter, which is another device that's deployed in the venous system that's used for patients with heart failure who are diuretic resistant. We know that up to a third of patients admitted with heart failure develop AKI due to cardiorenal syndrome, which leads to an increase in both morbidity and mortality. In acute cardiorenal syndrome, the hallmark of treatment is diuretic therapy, but that doesn't work all the time. As many of you know who are actually treating these patients, sometimes you get to a point where it's not working anymore. Reasons of which include, increased diuretic resistance, braking phenomenon, electrolyte abnormalities, et cetera, all of which happen frequently. And for these patients, there's really nothing else that we can medically offer. Device therapies have now emerged as a new treatment option for these complex patients, some of which come with promising data. The one that I'm going to be presenting on is the Doraya catheter, which is a renal venous flow modulator. This is a system here. It's implanted in the femoral vein over the wire at the end of the port, which you can see here. And at the tip, you can see this nitinol cage. This is not an impeller. This is not a pump. This does not have a motor. So how does this work? The mechanism of action is pretty simple. So the device is implanted by an interventional cardiologist in the cath lab. It's implanted percutaneously. It's implanted in the IVC near the kidneys, but just underneath the renal vasculature. And you can see, if you look at the cage area, you can see that there's an open state and a closed state. So this distal frame opening is modified to create a partial obstruction of the venous flow, which then is able to augment cardiac preload and venous congestion and hopefully improve symptoms for the patient. This is published data from their first 9 patients. This was a EFS trial, so early safety and feasibility. So the primary outcome of an EFS trial is safety, which I'll show what their safety data is because they enrolled a few more patients and then presented that more recently. So it showed safety of the device, so there were no serious device-related events. It also showed feasibility. What was feasibility? So in this trial, they defined feasibility of their approach as developing a pressure gradient of at least 2 millimeters of mercury during the procedure. Some of you ask, what does feasibility mean? Why do you need to do that? Well, these safety and feasibility, you need to show that you're not hurting anybody and that you're kind of doing what you said you were going to be doing, right? So they're saying, okay, well, feasibility for our approach is that this distal frame is opening and closing, which would be illustrated by this pressure gradient, which they showed. So from these 9 patients, here's their hemodynamic data. You can see that they offered full disclosure of all of these patients, showing improvements in CVP, improvements in urine output, improvements in patients' dyspnea score. Dyspnea score here, the higher is actually better, meaning less breathlessness and more functionality and reductions in edema. They then presented a larger patient population. This is N equals 12 patients last year at THD. These are the baseline characteristics of these patients. For the interest of time, I'm just going to point out that this is a typical heart failure cohort. You can see that a small amount of these patients did have preserved ejection fraction, but most of them had reduced ejection fraction. They did have some element of renal insufficiency at the time of the study, and their 24-hour baseline diuretic dose, this what I think is the most important part, 288 milligrams, but you can see that there's a very wide standard deviation. What does that mean? That's like the equivalent of having the lowest dose Lasix strip at 10 milligrams an hour for the first 24 hours and then failing that. So here were their safety outcomes. So the deployment time of the device was about 15 minutes. Dwell time was about 10 minutes in all of the patients. 12 out of 12 had all of their devices retrieved successfully at the bedside. None of the patients, like I said, had any device-related serious adverse events. One subject had one procedure-related serious adverse event, which was sepsis, but there was no unanticipated serious adverse events. Here's some of their hemodynamic data, which shows a significant reduction in the CVP from 21 to 16 by the end of the procedure, which was statistically significant. The minor reduction in wedge was not significant. All these patients also had improvements in edema, their dyspnea score, as well as their JVT, and urine output increased 3 times above baseline during the Doraya dwell of the catheter, as well as improvements in NT-proBNP. So just to wrap up with some brief conclusions, the Doraya catheter is a renal venous afterload reducer that is percutaneously placed, modulates flow by opening and closing its distal frame. Safety data showed no adverse safety events. Feasibility of the approach with the pressure gradient was confirmed. While only small studies have been reported, early data is promising by both reduction in CVP as well as improvement in urine output. Thank you so much.
Thank you. So now Peter Natov will be talking about the second concept. So this was all unloading of the veins, reducing preload to the kidneys. So I guess not preload. This is the afterload to the kidneys, the venous system. And now we'll talk about increasing arterial pressure to the kidneys.
Yes, thank you. Good morning, everyone. My name is Peter. I'm a cardiology fellow and research fellow at Tufts Medical Center in Boston. I have no disclosure. So, we just talked a little bit about devices and the idea of central venous hypertension, and now we're going to talk a little bit more on the polar side of things, as we mentioned. So, when we look at the schematic, we think of cardiac output, reducing forward flow to the kidneys, which results in a number of adverse neurohormonal activation pathways. It's a little more complicated than this. The kidneys do have autoregulatory mechanisms which can maintain vascular resistance within the glomerulus, and that's mostly at the level of the efferent arterial, so that initially the filtration fraction, or the ratio of the GFR to the renal blood flow is maintained, but over time, neurohormonal activation overwhelms the kidney and has deleterious effects. So the question at hand is, can we increase renal blood flow, and does increasing renal blood flow have any clinical benefit to patients? So pharmacologically, this is possible. As you may be aware, dopamine is one agent that actually has vasoactive properties on the renal artery system, and data both on the left, which is in patients with no heart failure, the administration of higher doses of dopamine is able to increase peak velocity within the renal artery and reduce renal vascular resistance, and that's mostly up to a range of 10 mics per kg per minute, which is what we refer to as renal dosing of dopamine. This has also been demonstrated in patients who actually have reduced ejection fraction heart failure, again, invasively looking at a flow within the renal artery, and again, dopamine does have effect there. But when this was studied clinically in a large randomized trial, which was ROSE IHF, unfortunately, dopamine fell short. So specifically, this trial looked at about 360 patients who were admitted with decompensated heart failure and had evidence of renal dysfunction, which was defined as a GFR of under 60, and the administration of low-dose dopamine at 2 mics per kg per minute, or low-dose nasiratide, which is a different vasoactive agent. These were given in addition to standard IV diuretic therapy, and the investigators tried to see whether decongestion was improved and renal function was preserved, and unfortunately, neither urine output, which was their marker of decongestion, or cystatin C levels were improved in these patients. So dopamine did not work. So as we mentioned, there's a number of device-based strategies to treat all the different parts of pathophysiology that relates to patients with decompensated heart failure, and some of these devices include what are have been mentioned as pushers. So these are devices that theoretically should directly increase artery pressure. Some of these devices, my colleagues will go into more detail into their data, but some of them are listed here, including the Raton catheter pump, the aortic device, and the second heart assist device. Basically, these devices work more or less through a propeller or axial-flow mechanism of varying sizes listed here, and they're positioned within the abdominal aorta above the level of the kidneys, trying to increase cardiac output and theoretically increasing renal blood flow. But I will finish on one part here, and I don't mean to be too controversial, but as was mentioned, the idea that cardiac output is a primary driver of renal dysfunction in patients who have heart failure is probably a little bit overstated. Sandeep mentioned some data from 2009. My research mentor from residency at Yale, Dr. Jeff Testani, he's investigated this question extensively using a number of post-hoc analyses of ESCAPE. And as you can see here on the left, when you group patients according to different cardiac index groupings, there's really no relationship whatsoever with any different markers of renal function. And similarly, cardiac index had no relationship in a different analysis with diuretic efficiency. So these devices, which I'm curious what my colleagues were showing, some of this early data, they really have a tall order into addressing this idea that if you really increase forward flow into the kidneys, to date, that doesn't really seem to work. But I think I'm excited to hear more.
Thank you very much. Way to throw some shade right ahead of the talks. It's good, it's good. It's going to be an interesting lunch break. Who's first? Imran, my partner in crime, Dr. Aslam from Duke University. Is going to be talking about advanced in MCS.
Thank you, everyone. Thanks for the invitation to discuss the Axial-Flow device in the aorta. So we'll talk about the aortic device. And so we kind of all discussed where devices sit in our vascular tree, venous or arterial, just direct LV unloading, RV bypass, and then venous congestion, which we've talked about. But then there's devices sitting in the aorta, and also where are we going to sit in the aorta suprarenal position, and whether that's going to be in the thoracic aorta or the abdominal aorta. We'll be talking about a device that's going to be sitting in the abdominal aorta, and that's the aortic device that was mentioned earlier. This was mentioned earlier today as well, but it's an 18 French device or pump that flows about 3.5 liters per minute at nominal speed. It's kind of an impeller device housed in a nitinol cage, which sits above the renal arteries, as mentioned. And after deployment, the actual drive line of it is a flexible, basically 6 French that comes out of the femoral position. And these are all implanted in the femoral position. And the introducer sheath is removed at the end of the case. And obviously, this device is built off the platform, as we discussed, really improving renal blood flow and trying to decrease, improve urine output, and off the premise of decreasing heart failure events and improving quality of life. And from a study that some of the authors on the stage showed several years ago, that actually if you look at the abdominal placement of this device versus in the thoracic position, it seems like the abdominal placement actually improves kind of distal aortic flow and improves pressure gradients and cardiac output and decreases arterial elastance more so than in the thoracic position. And so the device mechanism is essentially, as seen here, as I mentioned, an impeller housed in this nitinol cage. It entrains native blood flow into the pump. Flow accelerates, and obviously there's an increased velocity of blood flow, and that pressure gradient created there. And the whole point of it is, again, to improve blood flow to the kidneys, facilitate action of diuretics, and decongest and improve renal function, obviously decreasing neurohormonal kind of activation with this action, ultimately improving some cardiac output locally there and decreasing afterload. Again, there's been some animal studies showing that looking at this device in the suprarenal position, that it can increase cardiac output, decreases afterload to some degree. And so so there was a pilot study several years ago that looked at using the device in about 18 patients. These are patients that are considered for enrollment only after they're admitted for decompensated heart failure, worsening renal function. They were found to be non-responders, so to speak, to IV medical therapy. As discussed earlier, these definitions of diuretic resistance are a little bit nebulous, but these are patients that had a cumulative dose of Lasix of 720 milligrams daily and were still deemed to be persistently congested. These are patients who were getting thiazide diuretics and low-dose inotropes as well. And this is the patient demographics as shown here, and mostly HFrEF patients, but some HFpEF patients. And you can see essentially the results of this. To summarize, the net fluid loss over the ensuing several days after the device was implanted was clearly increased compared to the preceding days. All the metrics that we would look at, CVP, wedge pressure, GFAR, serum creatinine, and dyspnea, all improved in this trial. There were obviously some vascular complications that were minimal with this device, though, again, just to reiterate, it's a 21 French device initially going in, and once the patient goes to their bed afterwards, it's essentially a 6 French at the groin before removal. Obviously, it requires a separate procedure to have it removed afterwards. And so the DRAIN-HF trial, which is currently enrolling, is again looking at all patients admitted with decompensated heart failure, any ejection fraction, who are again assumed to be persistently decongested, randomizing 1-to-1. There is an advanced heart failure registry arm of patients as well. In the prior trial that I mentioned, about 40% of those patients actually were bridged to advanced therapy. And so there is an advanced heart failure registry for this trial, and looking at the safety endpoints. as shown here, really looking at heart failure hospitalizations, whether there's escalation to advanced therapies or worsening heart failure within 30 days. And the composite endpoint really comprises of achieving this minimal 7 liters of net fluid loss during hospitalization. And just to, as I kind of wrap this up, I wanted to go over kind of the pros and cons of these sorts of pumps. So we discussed this earlier today a little bit about the concept of having a pump in the aorta versus in the LV and the potential benefits and cons of that. But when you have a device that you can put in the aorta, you have the kind of the advantage of if there is an intracardiac thrombus or mass or issues with the aortic valve that preclude using of such a device. These devices have that advantage. No obvious valvular contraindications, but obviously the cons being on the right, it is a large bore device, and it is, if there is any need to access the aorta, again, there is the fact that this device is kind of jailing the aorta to some degree. It's partial circulatory support, and that is one of the downfalls. But again, this device was really built off the platform of cardiorenal syndrome. But these devices, I would propose, just kind of as I wrap up here, is that these devices really, as we have different iterations in the future, I think the question is how versatile can these devices be and the durability of them long term. If we are going to bridge them to VAD or transplant, how long can these devices stay in compared to the current devices that theoretically increase renal blood flow? So I'll wrap it up there. Thank you very much.
Thank you.
Thank you. For our next lightning talk, we're going to talk about puzzle with Dr. Peter Fail.
I kind of like that whole idea of the number 2 pencil. I'm gonna steal that. You guys have been listening to heart failure lectures all day, and I think there's one other interventionalist on the panel here. So I'm the other quasi. We're going to talk about Puzzle Medical, which in my opinion has the best name for a company. These are my disclosures. I'm just going to really go over the first in human that was done 2022. These are 4 patients that were done in Paraguay. And basically it was done for high-risk intervention was the idea. It was a modular device, 3 endovascular pumps inserted in a serial and assembled in parallel, self-expanding anchor, and I'll show you a little video clip about that. It planted into the descending aorta. This is what it looks like. It goes in 3 pumps, if you will. It has a nitinol anchor that's basically at about T10, T11 above the renal arteries. This is kind of what it looks like going in. 22 French sheath in this iteration. It's been reduced now to 14, I believe, in the femoral artery and 10 in the axillary artery. You can see how it can go both. This is the 3 pumps, and then they're actually pulled together, opened up with a nitinol anchor, and then the 3 pumps are pulled down. And then basically reverse to pick the whole thing back out. You just basically pull each pump in individually back into the system. So single arm, open label, single center perspective, 4 patients, high risk angioplasty, 22 French sheath, all above the renal arteries at a T11. Takes just a few minutes to put in, about 8 minutes. Support time was just under an hour to do the intervention, and coming out was about 7 minutes. Obviously, we talked previously about pre-close and things like that needed to do these things. The mean pressure gradient across the pump itself was about 5 millimeters of mercury, period. Basically needed 2 proglides. They did have a right heart cath in the right femoral vein. They did all their intervention from the right radial artery. That also begs the question about the other devices going into the descending descending aorta, that it precludes any intervention coming from the femorals. Pigtail was in the abdominal aorta and the femoral artery, and then interesting, rotating about 14,000 RPMs to deliver 4 liters per minute. They measured LVEDP, CVP, PAs, cardiac outputs, and pre and post pump pressures. Basically, all the baseline measurements were done 15 minutes before and 15 minutes after the removal of the pump. Cardiac index was improved by 25%. Central venous pressure went down by 37%. EDP went down by 78%, which is remarkable. And then probably most important in this sort of symposium is the increase in urine output. 9-fold in about 15 minutes of support with significant improvement in diuresis. If you actually looked at complications, there was no real increase in LDH or plasma-free hemoglobin, so no worried about hemolysis or the reduced von Willebrand factor. The first-in-man study showed there was no device malfunction, no procedural device related adverse events, and no pump thrombosis. All patients were alive at 30 days. This is basically just a cartoon, or if you will, of the whole device itself. Goes through all the things we had just mentioned. And obviously the comparison of all the devices that are currently out there, the balloon pump, the Impella CP, the 5.5, the ECMO, and then the Ortex you just heard about, and then the module heart device by Puzzle. So the advantage is obviously no crossing the arch, and I think that may have some plus or minus, especially in something that's long-term access. May have a lower stroke rate versus an LV pump, may lower, obviously, the ability to lower the size now to 10 French for axillary and 14 for femoral. And I suspect as more iterations come, that'll even go even smaller. 3 pumps rotate at a lower RPM, which decreases the issues for hemolysis and destruction of von Willebrand factor. Obviously, a marked increase in urine output over, especially for those heart failure patients. Obviously, disadvantages was going to be the stability elements, which may include femoral access. Concern for recirculation. Do we actually cause a recirculation issue? Did not directly unload the LV, although there was a marked improvement in LV EDP. And then obviously you have to worry a little bit about a Venturi effect, especially in people with critical coronary or carotid disease. Oh, let me see if I can go back one. So obviously we're seeing the first-in-man inserted in a series, assembled in parallel, improved hemodynamics, significant urine output improvement, a low complication rate, and obviously the EFS is going to be planned. I understand they just got a $43 million endowment in April, so you'll probably see that next year in EFS. Thank you.
Thank you. All right, last but not least, our last talk about fearless leader, Dr. Esposito, second heart assist.
All right, thank you everyone again. This is the last talk of the session before we go out into discussion, and I'm just going to take a break here because I see that there's a few trainees in the audience. And I remember when I was a trainee, nobody said this to me formally. I kind of learned it along the way. But you must be thinking, what are you all talking about? First in man, EFS? Like, what's the relationship between these steps? What all these things mean? So when you're talking about device therapies, everything happens in sequence. It's a very nice standardized sequence. It's nice for you to understand the steps so that you can put into place how much work has been done. Because between steps, it's not days or weeks. It's months and more often than not, years. So there's an immense amount of work that goes into advancing a device to the next stage. So we really have to appreciate the enormous amount of work that has gone into researching these devices and pushing them forward clinically. But when you start with a concept, right? You can take that concept for a pump, let's say, for a device, for something that you're putting into a patient. You have a concept, you can show that to some engineers, you can build some stuff, you can do some in vitro testing, and then, using some off-the-shelf products, hopefully, because it makes it cheaper for you, you can find this stuff in the hospital, you can then go into preclinical studies. What does preclinical mean? It means you're implanting these stuff not in humans, you're implanting it in animals. If that all looks good and the animals don't all die, then you can move on to the next stage with your initial round of it. Iterating on your hardware, your device, whatever it is, and do a first-in-man, which is usually a handful of subjects. You're doing it for the first time. That's what a first-in-man is. If that looks good, then you can start with an early feasibility study. You're looking at safety, you're looking at feasibility. And that's usually a few more patients, but it doesn't have to be a large amount. Then you move on to the pivotal. The pivotal is the big one. Is this really working? Am I really changing something in a serious way that's going to affect clinical practice? So I just wanted to pause because this talk is going to be pretty short so that you can kind of frame this when we're thinking about it. I'll be talking about the second heart assist platform, which doesn't have too much clinical data, actually. This is targeting patients with decompensated heart failure who suffer from diuretic resistance, reduces afterload as the impeller blades draw blood into the pump, maintains arterial pulsatility because, again, this is another intra-aortic device, isn't going into the heart. And it's placed above the renal arteries by about 10 centimeters to theoretically increase renal perfusion, supposedly by about 50%, and mitigate the effects of intrarenal vasoconstriction. So this was the first iteration of the device. It's a 13.5 French impeller-driven pump. So think about that. That's an important thing to think of. When you see these devices, how big are these devices? Especially if it's an arterial device. 13.5 French, that's the size of an Impella CP. CP is 14 French. Okay, so that's what it's comparing itself to. That's a big device. It's mounted on dry drive shaft inside a stent cage, okay, and it's delivered percutaneously, like I said, right above the renal arteries. It provides about 2.5 liters per minute of flow above native output, and initially they had 2 iterations of their device. The first one was this, and the second one was supposedly this removable chronic wireless implant, so the patients could go walk around in it. It was not connected to a drive line. They did their first in-man study for high-risk PCI using the device that I just showed. So 4 patients with heart failure and complex coronary disease underwent implant of the device during PCI. All patients had successful insertion of the device via femoral access in less than 2 minutes. They achieved a minimum of 10 millimeter mercury gradient across the pump, which averaged 8,500 RPMs. Duration of support was an hour in all patients. They underwent multi-vessel PCI. The device was removed percutaneously in all the patients. No patient experienced a serious adverse event. And there was a 4-fold average increase in urine output from baseline and no change in creatinine at discharge. This is their second generation device. They called it the Freedom device. This is the device that was supposedly supposed to go into the body. No need for a drive line. A patient can go home and walk around with it. And the power device is actually inside this waterproof vest that was supposed to be worn around the chest. So you put this device in, and then how do you recapture it? Because it has to come out of the body. Well, it's through this tip, which has this magnetic ball that's supposed to help dock the device and retrieve it out. This, as far as I know, has not been implanted in man yet, or at least there's been no publication of the data. This reminds me, I don't know if y'all have seen the movie Interstellar when like Matt Damon's trying to dock. I don't know if anybody knows. This literally reminds me exactly of that. If you haven't watched Interstellar in a while, go watch it again. You'll see exactly what I mean. This is the most recent, as far as I know, iteration of the device. This is their Whisper, and the data that I'm publishing here, or that I'm showing here, is from a publication they had this month in Artificial Organs. So you can see that the pump head looks identical to the previous iterations of the device. They've made some updates to the catheter-based controller, the ambulatory controller, and the motor. But again, it's implanted right above the renal arteries. And this was an in vitro hemolysis study. So they designed these 2 circuits, put the pump in, and then compared it to the same circuit that had an Impella CP pump, and then filled the circuit with cow blood. Okay? And then they ran the circuits at really high flow rates. So they ran the Whisper at 10,000 RPMs, producing a blood flow rate of about 8.5 liters per minute. Okay? And then they measured these HQ curves. If you're ever studying devices or centrifugal pumps, anything like that, you're going to see an HQ curve. What is an HQ curve? It's monitoring the pressure head of the device versus the flow. So all the red lines are the Whisper device at escalating RPM. So the bottom is 3,000 RPMs, and then the highest red line is 10,000 RPMs. The blue lines are all the Impella CP. The lowest rate is about 23,000 RPMs, all the way up to the top is 46,000. So the Impella CP consistently generated a higher pressure head than the Whisper at the same flow rate, so it might be better at higher levels of unloading, which is as it's designed. On the Impella CP curves, you could see extend all the way out to 8 to 9 liters per minute of flow. But you see the Whisper tapers earlier. We know that means that the CP has a greater flow capacity. Again, something we could have already predicted. But the Whisper might be more efficient at the lower flows. So you can see that the red curves, the Whisper curves, are near or below the blue curves at lower RPMs. So might be better for partial support. At least that's what I'm gleaning from these HQ curves. Compared with Impella CP, the Whisper had significantly lower indices of hemolysis. You're saying, how do you measure that from an in vitro circuit? Well, they draw samples of blood from the in vitro circuits and measure plasma-free hemoglobin. So there was lower indices of hemolysis in the Whisper compared to the CP. And just to wrap up with the conclusion slide, Second Heart's a novel percutaneously deployed impeller located in a nitinol stent cage, sits above the renal arteries. Future studies in human subjects will need to adjudicate some of their early findings, given the growing prevalence of circulatory support devices that are smaller profile, and this is kind of my main dig. This is a 13.5 French system. Future studies will need to focus on the risk-benefit ratio, especially because this is quite a large device. Thank you so much. Now let's open it up to the discussion. I do want to hijack the first question, and I want to bring it back to some of the earlier talks that we had, which were about hemodynamic monitoring. And I know that we missed Dr. Uriel's talk, and he was supposed to be talking about non-invasive sensors. And we have all these gadgets and widgets and gizmos and all these things that measure intrathoracic impedance that measure, the duration of a certain EKG signal, et cetera, but the issue with that compared to the PA pressure sensor monitors is that none of them are clinically relevant. So if I told you what somebody's intrathoracic impedance is, there's no standard of workflow you'd be able to act off of that. So my question for the group, particularly the folks who have presented on some of this hemodynamic monitoring devices, is there truly a role for a lot of these non-invasive devices that aren't linked to any known clinical correlate?
I'll take that one. I take offense on that one. So I think that we got to be very careful. I would argue, and I do pressure sensor implants all day, every day, that even the pressure sensor is giving us a false clinical impression of the actual congestion state. It's certainly all these sensors, whether they're impedance-based, multi-sensor, lung water content, pressures, IVC, they all indicate congestion. Now, congestion is a very complex concept as you sort of, the elephant and the blind man, you can sort of attack from all different directions. The problem is if you assume the congestion is measured by pressures, and that automatically means then diuresis, which is often done in clinical practice, you often actually run into a wall pretty quickly, and in many patients, that's actually the wrong strategy. So I would argue that we do a lot of heart logic management, non-invasive vests, and all that stuff, that if you use that cautiously as a volume signal, but certainly acknowledge the fact that in many cases, just like a red flag, if that sensor indicates abnormality, whatever that value or unitless value is, that you say that patient needs to be seen because they're in trouble. I think non-invasive are going to be a lot more like that till we get to a point there's non-invasive sensors coming that are directly correlated to pressure. Jaime has done a trial, has enrolled in a CardioSense trial. There's an Acurai-related device. So now they will try to emulate pressures, but I would argue it's very dangerous to say, okay, and diuresis is the answer to that, because the much better question, and I'll sort of send it back to you all. Now, CardioMEMs is a fantastic device on the market since 2016 and 17, something like that. We have implanted just over 40,000 devices in the United States, and we have like 7 million prevalence at any given time. So what the hell is going on? Why don't we do more of that? It's mostly reimbursed now. The numbers are not exploding either. And what do you see as the biggest impediment in clinical uptake? Esther, yes. I know you have strong opinions. Here we go.
So one is that, just to handle your answer before, for a less fancy answer, is there's a lot of room for improvement, and so the device doesn't have to be perfect to make some headway. So yes, we always have to take any therapeutic, diagnostic intervention that we do, knowing that it has limitations, but their limitations don't throw the baby out with the bathwater concept of even if we're using surrogates and they're imperfect, they're still better than patients just weighing themselves every day, sometimes weighing themselves, sometimes not. So our biggest impediments, so we have like multiple of impediments. So yes, now it's widely approved, but that was probably in the last year, right? I forgot what the terminology is for, there's some acronym that, NCD, thank you. Once the NCD got approved. So, and we've seen an uptick. So first is, I think, insurance was a big issue. Two is you have to have programmatic support, right? Implanting them it's not a therapeutic intervention. You have to have someone monitoring it, and you have to have a system created to do that, and to have a hospital system that supports that time. And so the problem is the more people you support, the more people you implant, the more people you support, the more of those people you're going to need. And so I don't think everyone has that, has thought out that system well and has good people doing that. But I think we did. And so our first impediment was that doctors weren't doing it, right? So like when you get a denial for us, it was Blue Cross Blue Shield like 5-6 times, you then, it's like, do I spend my 20, of the 20 minutes I have with a patient discussing something that's not gonna get approved? Or do I focus on something else? And so first we had to get past the doctor hurdle. We created a good system. There's a doctor hurdle. You have to get, if you have an APP system, I think they touch our patients a lot more than we do. And so I think they have more touch points. So I think we need to employ them. And then the insurance, I don't know if everyone quite realizes that it is more approved starting last summer. And I can tell you my team, when they just switched, right, the private insurers still tried to deny it, which isn't allowed. And I got an email from my team with the exact verbiage that I'm supposed to use, that like the number of the NCD or whatever, and like, here's what you say. And then I just went and I'm like, this is what I'm gonna say, I'm gonna read it to you, And then they're like, okay, we'll approve it, right? But like, not everyone has that. So that's
Can you send that to me?
yeah.
I mean, I think you're valid, right? I mean, you know, the biggest hurdle we have in Louisiana is Blue Cross Blue Shield. It is absolutely the biggest hurdle. And when you do a peer-to-peer with a pediatrician who has no idea what you're talking about, you know, and they'll admit, hey, I'm a pediatrician. I don't know anything about heart failure. I don't know what this CardioMEMs is. But it looks like it's a funny code here, and we don't approve it. And you say, well, you know, I just had a 20-minute conversation with my patient, and I told him all of the reasons we should be doing this, and then you tell me you're not going to do it, and the patient says, well, I'm not going to do it. My insurance company says I can't do it. So that's always been a big thing. And so if you have a little blurb that I can say to Blue Cross Blue Shield, you know, that would be worth its gold.
And also, Marat, I think that argument could be taken to GDMT too, right? Is what's the uptake of GDMT, let alone CardioMEMs, let alone who follows CardioMEMs, is very low. And I wish there was a good enough answer to say, well, wouldn't that be nice? The second, as Esther pointed out, is the issue of it takes an army to follow these patients. For example, we got approved for once a month CardioMEMs monitoring clinic, which kind of defeats the purpose of doing it regularly, and so on and so forth. And I think hopefully eventually it'll get to be back in the hands of the patient, because I think that would really solve this whole who's going to monitor it, who's going to tell them. As our patients get more and more engaged and involved, I think hopefully we'll see further uptake of this therapy, because you shouldn't have to, you know, rely on beyond a point healthcare providers to fix everything, make patients self-sufficient with this device one day. I mean, I'm not saying we're there yet.
I'd also say it depends what system you work in. Like, not everyone, right? Like, budgets are different. And so someone's looking at, okay, we're getting paid for CardioMEMs, great, right? And then someone else is looking at readmissions, great. And then someone else is figuring out how many nurses you're going to hire. And they're not, depending on your system, you got to figure out who those people are and have them talk to each other so that say, hey, we'll reduce readmissions, which is going to save you X, but you need to spend Y on people, but the budgets might be different. So you have to have someone who actually understands that, which is not me. I just understand it's complicated and I don't like doing it. But there are people who need to kind of be looking at budgets in different places. It's like when insurance won't approve some medication that costs $1,000, so we keep someone in the hospital for a week, you know, for 3 days for $30,000, right?
No, I was just going to echo what you just said in terms of the platform for these devices requires really all the dimensions of the disease spectrum and the accountability of the organizations towards saying, okay, we're committed to reducing readmissions, to provide longitudinal well-being for patients with heart failure at all stages. And of course, you need to have the human resource to follow, to have the blueprint of why are you using this device. I think the more that we learn about, you know, the true reality about congestion and pressure, volume, and all that. You know, I go back to the index right heart cath before implant, and exactly what was going on there. The patients were already congested with normal end organs. They have already optimized their medical therapy or their device therapy. And if not, if we just put the device because we wanted to follow them after readmission, and none of those things are present, I think the device is really not going to help you follow them accordingly. So really having an infrastructure of making sure that you personalize the care of that patient with doing all the other homework beforehand, then I think is for us has been transformative. We have reduced readmissions. We have really used it in so many different settings, including after durable LVAD, to try to understand more when they're getting sick and really titrate their flows based on hemodynamics. But it does require a big commitment from the institution to provide that human resource from nurses, coordinators, and advanced practice providers to follow these patients.
Which, to bring back to the kind of question about using non-invasive ones in Marat, you know, so even if we increase, you know, we also been implanting way more, been more covered. 40,000 patients in 10 years, there's 7 million people with heart failure. Really, we'll never implant everyone with a CardioMEMS or a different PA monitor sensor. And so using these non-invasive tools, not only do you, as Jaime said, to attach that to an index right heart cath and use that as a relative sense of, instead of just doing exam, which plenty of data shows we are all, even us heart failure doctors, are not the best at the physical exam, looking for those changes. What are those touch points? What can we adjust as that goes over time? I think has been, and then the other part is a lot that I know Marat has done, where really finding, personalizing to the patient of not just pressure, what is their volume, how does this interact with their other non-invasive tool, and then you, for that patient, have your tool that you can bring them kind of to optimization, even if it is a surrogate.
I think the challenge for all these devices, simple, outpatient, non-invasive, invasive tools, is the scale. Not the weight scale, but how do you scale, right? I think, Marat, you made the point of, we've had now MEMS for 10 years and 40,000 implants. That's pretty modest, right? I think we have 64 million humans with heart failure in the world, and 6 million of them happen to live in the States. Why aren't we implanting more? And I think the issue is it's workflow and it's the scale. So to scale, the data must be pushed back to the patient. That is how we scale. Obviously, not every patient can manage this, but there's a good chunk of patients that can and should manage this. I think if you look at some of the trial data that was presented today, patients, when they have data, are highly engaged. Not every patient, but many patients will be. And if you take that engaged patient, you give them simple tools. They don't have to have the sophisticated, why you're decompensated, what's your venous capacitance, how much blood is in your venous side versus arterial side. That's too complicated for them. On the outpatient side, give them simple instructions on how do you manage this decompensated episode, whether it's vena cava management, PA pressure management, or some other non-invasive seismic tool, or some other, metric. The challenge, I think, as I see it, just looking at the pure numbers, I work with another partner in private practice here in Austin, and he and I both manage our heart failure practice of probably several thousand patients. We have 2 or 3 nurses. When our several dozen patients get hospitalized a month, we have dozens of nurses hands-on in the hospital. So hospital-based therapies, lots of help. Office-based therapies, outpatient therapies, virtually no help. Patients are sort of at a loss. My nurses are at a loss. I'm at a loss. So these tools that we're going to use for the future really need to be scalable, where they're simple, they're accurate, they're helpful, they're not harmful. And I think that's where we'll not only show an outcomes benefit, but we can also scale. Thanks.
Yeah, I have to say, and I'm going to answer my own question, but my short answer is, and I'm being negative, but I do think that, we do that all the time, right? We find a number that doesn't have any actual clinical application, and we use it, right? Like I'm a full-time interventionalist and a part-time heart failure doctor, so I'm probably going to completely botch this, but from my memory of taking care of transplant patients, we use a DSA, right? Like in a number cutoff for like rejection or something like 30. Something like that, but otherwise it has no actual clinical relevance. But I think the burden on these non-invasive devices is going to be high, and I think it's actually almost going to be higher than the implantables, because if you're going after something like a PA pressure, like I know what to do with that. We've all known what to do with that. So I think that they're just going to have to enroll more patients. Some of the red flags that I see, and it's so interesting because all the young kids, all they want to do is find another wearable, like a anklet or a bracelet or a watch or a ring. And it's like, I feel like the problem with our patients is they don't want to have a wearable. I think Mark's slides showed that a few of the competitors in the field of non-invasive monitoring are a couple of chest straps. A few of them are. Zoll is doing intrathoracic impedance, but they had to look for a lot of different sites and scan a lot of different patients to enroll. And I think it's because a lot of these patients are going to fall. They're not going to use that every day. At least my pessimistic thought is that if it's a true wearable that needs to be worn every single day, that's going to be a huge impediment. I think something where it's a touch point is going to be a lot more successful in increasing patient compliance. So I want to circle back to the second half of the session and ask a question relating to our venous and arterial devices that are being implanted, not only in the SVC and the IVC, and also intra-aortic. And I always thought about this, and like one thing that I always think about, I'm like, okay, cardiorenal, diuretic resistance, but in my head, I'm like, is that a little too late? Like, how long are we waiting before, we want to implant these patients, particularly with the venous devices? Like, I'll implant a venous device on anybody. I mean, like, everyone's like, do you want to close the groin? It's like 18 French. I'm like, no, just hold pressure. It's venous. So I'm wondering if we should actually be capturing these patients more upfront. And I wonder what y'all think about that.
Yeah, I'll take a stab at that. I think, Michele, I'm always consistently amazed at how decompensated patients are going into high-risk PCI when they're laying comfortably on the table, with O2 for nasal, just for comfort. And we just dip the ventricle and we're like, oh, LVDP is 38. How about that? Maybe we should do a right heart cath, and maybe we should actually admit them for a day or two and get them tuned up. And this is somebody who just came in from home. All their belongings are neatly folded, right? So I think we're missing the boat. By the time they have sort of, asked for help, come into the hospital and say, I'm not well, we've already missed the boat on this. I do think also on the issue of arterial versus venous, as a TAVR operator, I'm well familiar with up to 22 French, percutaneous with a bunch of per closes, but I will tell you that putting in a 18 French device with a 21 French delivery system and a 21 French retrieval system, dwelling 4 stitches, locking 2, breaking 2, adding a 5th stitch post-close, it's a lot, man. It's a lot. I think that, there's a 15 French version of Procerion in the works that's in animal studies that look good right now, but I think that, as you said, if venous works, I think that's a much more elegant solution, and then we sort of build screening protocols around that.
And even for venous, I enrolled 2 patients in it. The criteria as demanded by the FDA were insane. Like, you have to fail 200 milligrams equivalent of Lasix and still be making less than 200 cc's an hour of urine. It was very, very specific. So it wasn't coming from a clinical rationale that you've exhausted every single option and only then can you proceed. But I think I don't know where it's coming from, diuretic resistance, and then you dip into, is it urine sodium, and do we buy that? I think eventually, once these devices get approved and we get comfortable with, I would imagine their role is a little bit more upfront than everything else has failed. So let's try this, because that never works with anything.
I will just add that, if congestion is a disease, we have been talking about, low cardiac index is not perhaps as a determinant for outcomes as congestion. We have really simplified and dichotomized managements and honestly outsourced management to internists and hospital medicine about patients that are at super high risk. And I think it's upon us, upon the community. I mean, we don't see, unless you're, Duke, Cleveland Clinic, Mayo, like units of heart failure run by interdisciplinary team led by advanced heart failure specialists. Basically are very comfortable with this readmission up until readmissions become a problem, and then the administrations come to the heart failure leadership for reduction is when we try to tackle that. But across the United States, there's a big issue here of access, of truly trying to own the disease, and the diuretics are not the answer, that's for sure.
Yeah, and one comment on that one is I think it requires a little bit of a mindset change to use device-based therapies for decongestion, but not think of that as MCS. Because every time we think MCS, that's Jaime putting in, a big pump for destination therapy or bridge therapy. I think it just requires a mind shift, and we're not quite there yet because the heart failure docs, to some degree, have been the non-invasive specialists. So we're very, very comfortable with drugs. We overuse inotropes. So I think it's going to be time.
Which has been the big argument, I think, from the interventional community, that the heart failure doc was sort of like that black hole. So if I sent my patient to the heart failure doc because they have decompensated heart failure, I never saw them again. They were gone. So I think that was an argument there. No, it really is. I mean, I think that's always that, and I think there's specialties that are less siloed. Not to do. I'm going to start sending them back to you, Marat. But I mean, I think that's always a big argument. And the other issue you brought up about are we doing too late? I mean, I think that's been sort of the genre of medicine. We tend to wait till the patient is at the very end of the spectrum, and then we say, let's try to do something. All our trials are, look at COAP, for instance. I mean, we drowned him in guideline-directed medical therapy before we put a clip in him. You know, and so, yeah, so that there needs to be some way where we could do this to say, let's try to do these together as opposed to drowning in medicine. How many of you have all your patients on Jardiance and don't have a patient that doesn't come in tomorrow morning or Monday morning and say, I cannot afford my drugs? I mean, that's the number one reason I stop all my heart failure drugs is cost. And so, you know, their guideline-directed medical therapy, you know, is valsartan and a diuretic because they can't afford anything else.
Yeah. Fair enough. Yeah, no, I would say just in terms of the kind of going too late, my understanding is some of the, many of the devices we talked about for renal perfusion, my understanding is kind of FDA related and they need to be specifically attacking diuretic resistance, when maybe what this is more is something like SkyB shock, which we know from the cardiac shock working group is associated with such high mortality. So you say we're catching them too late, and it's because we're not treating diuretic resistance, we're treating shock late with the device. We know that earlier devices tend to help, so I think maybe, but I know that's responding to the incentive of how these trials need to be set up.
Thank you, everyone. Thank you to all the speakers and the panelists on this session. We are going